Okay, so the first article, we're going to cover three. I'm going to talk about this study that's a geospatial analysis of ED visits targeting community-based responses to the opioid epidemic. It's a study that came out of Mass General, published in PLOS One in 2017, with the study question trying to understand whether emergency departments can use visit data to identify hotspots of opioid-related healthcare utilization, with the goal that you would then use that information to prompt further investigation, deploy resources, and engage the community to tackle the problem. Thanks. So this is a geospatial analysis, like I mentioned, Massachusetts General Hospital records from 2012 to 2015, basically looking at the reasons for visit to identify opioid-related visits, so things like narcotic overdose or abuse in Charlestown, Massachusetts. Now, anyone here from Boston? How is it pronounced? Is it Charleston? Charlestown? Charlestown. Okay.
We have the author.
Yeah. Yes, both. Both. Okay. We Googled it last night and listened to different pronunciations. Charlestown is north of downtown Boston and east of Cambridge. It's got one zip code, but 6 census tracts. And the idea here is that addresses, home addresses for patients who presented to MGH were spatially located to one of these 6 census tracts and then aggregated in the census tract. The strengths of the study is it's got a good sample size. The authors did a nice job controlling for confounding around population differences, around clustering in households. Limitations are that the unit of observation that the visits were observed in a single ED as opposed to looking at overall all healthcare utilization, and that you're using the patient's home address as sort of a surrogate for where they're coming from, but that it's not actually locating the location of opioid use. So here are the quick results. 45% of all opioid-related ED visits in Charlestown came from a single census tract. And as you can see here, there is, in fact, a hotspot in this location right there. There's about a 9.5-fold difference in visits between this census tract and this one. And even when you control for things like the number of households, unique addresses, you end up with still a 5-fold difference. And these differences can't be explained purely by population differences. And within this single census tract, if you look at all the ED visits that originated from that census tract, 4% of them were opioid related. So obviously a huge, huge problem. And so the takeaway from this analysis is that you really can view this opioid epidemic from the lens of the ED to highlight the heterogeneity associated with space and location to identify problems within the community. This can obviously have implications for bystander naloxone, addiction treatment centers, future exploration of spatial factors that drive these differences. And I like this quote because I think it's applicable to more than just opioids. In instances where conditions are strongly tied to place-based social determinants of health, granular data like home address and other demographics can be used to target limited resources where the problem is most severe. And so you can envision a scenario in which we can leverage a patient's address in real time to surveil the community for problems. So you don't have to do this retrospectively looking at a single disease, but if you a priori define the disease and have an ongoing surveillance, you might be able to deploy resources in real time. So I think it's a fantastic study that sort of shows where the future of spatial epidemiology and emergency medicine can go.